a degree, but again, that can come down to some personal things. I mean, I was making a phone call just the other day, and there was a recorded voice, a human voice saying, "We look forward to servicing you when an agent is available." And yeah, it's great terminology, but you can tell by the inflection was very flat and everything else. So if there's not authenticity behind it, it doesn't really matter. A lot of clinicians are using it to maybe simplify their notes. As long as the AI isn't like generating the note, I don't think it's quite ready for that yet. And I've heard a lot of stories about getting people talk about AI hallucinations and things like that. What it's hearing and what it's trying to assemble and all that.
So let's talk about digital overload. So Mike, based on your experience, like the way you were just discussing that when you go to any clinical appointment, most of the time the provider is looking to the monitor and they are just typing. So do you think these digital tools are making a lot of overheads, a lot of paperwork and a lot of data entry for providers and for clinical staff instead of focusing on the core problem?
Wow, that's a question. The future of digital health should be, again, as a companion. Clinicians, since time immemorial, have had resources, whether it's books, whether it's apps, whatever it is, that help them make decisions. Where technology can help, and artificial intelligence and everything else, is to make those decisions a little bit easier.
So welcome to Better Health Tech, the podcast where we explore how tech make the healthcare operations smarter, faster, and easier for the people doing the real work. I'm Muhammad Atif, CTO of PureLogics and Better Tech Health, where we build custom healthcare and enterprise tech solutions focused on solving real operational challenges. Today, we are joined by Mike Hess, Senior Director of Advocacy and Regulatory Affairs at COPD Foundation, and a respiratory therapist with a deep experience in patient advocacy, respiratory care, and healthcare policy. Mike brings a very important perspective because he understands both sides of healthcare, the clinical side, where care teams are under pressure, and the patient side, where people need empathy, education, trust, and support. And today we are discussing a topic which is very important: how healthcare teams can use digital tools without losing the human side of care. And this topic matters because healthcare is becoming more digital every day. We now have telehealth, patient portals, remote monitoring, AI tools, automated reminder, digital intake forms, and data-driven workflows. But here is the real question. Are these tools helping people feel more cared, or they are making healthcare feel more automated and less personal? Especially for the patient with chronic condition like COPD, question is even more important. Near 16 million adults in the US have COPD, and many more have it without knowing. COPD is also one of the top 10 causes of the death in the US. So when we talk about digital health, we are not just talking about convenience. We are talking about access, education, early intervention, and quality of life. Mike, thank you for joining us today.
Thank you for the opportunity. It's a pleasure to be here.
Thank you. So Mike, before we go deep into this topic, I had loved to hear about your story, and if you can share for our audience your background, please.
Sure. Happy to. I've been a respiratory therapist for about 20 years. And I always joke, I first got into respiratory because the waiting list for nursing school was too long. I knew I wanted to do something in healthcare, and by that point in my life, it was a little bit late to go to medical school or anything like that, or to even think about that. So ended up being a respiratory therapist, and fortunately, it was very serendipitous, and I've never looked back. It's been a great career. Started, as many of us do, in the hospital setting, ER, intensive care, that sort of thing. Eventually moved on to more of a ambulatory care role. I was able to, as I continued my education and got my bachelor's and later a master's in public health, it was able to work in a primary care office doing a lot of disease coordination or care coordination, disease management, education, that sort of thing, which has eventually led to me at the COPD Foundation, where I get to do that on an even larger scale. So it's not necessarily direct care anymore, but it's certainly very gratifying and very satisfying. And I'm really pleased and honored to have the opportunity to affect healthcare for so many people.
Well, thank you, Mike. Really interesting and great story that you shared with us. So it seems like you have worked closely in respiratory care, advocacy, and regulatory affairs. So tell us, like, what inspired you to focus your career on improving care for patients, especially those living with chronic respiratory conditions like COPD?
Well, it's one of those things that I was able to. Again, this was probably about 10 years ago. Identify there was a gap. This was about the time where the Affordable Care Act had passed, and there was the hospital readmission reduction program. And one of the in the second round of that, one of the disease states was COPD, trying to reduce the unnecessary readmissions and improve care in general. And I saw that we certainly in the U.S., but arguably around the world, were doing a fairly poor job at giving people the tools they needed to actually manage their condition. This was one of those things where a lot of providers or prescribers would see somebody. They're like, well, you've got COPD. Here's a couple inhalers. Good luck. There's not much else we can do. We'll see you again in 6 months, and then just kind of start running out the clock. But truly, there are a lot of interventions that can be done. While there is no cure for COPD yet, there are a lot of ways to help people really live their best lives and increase their longevity, increase their quality of life. And so I saw there was that gap in teaching people that. And as that continued to grow, I became very, very passionate about educating people. I actually started a Facebook group to provide some peer support, but also some structure. There were some groups that were on there already, but they were all very much peer to peer, which is fantastic. But sometimes you just need a little bit of objective clarification and things like that. So, and then my first entree into the policy space was after I had started working in primary care, working with our state Medicaid program here in Michigan to, they were making a lot of decisions about what inhalers were covered and things like that weren't necessarily in accordance with best practice guidelines. And so I was able to get into some advocacy there and really caught the bug there, so to speak. And just it's been a very interesting journey, and it's something I really enjoy doing.
Well, thank you for explaining all your journey and all these details. So it seems like healthcare is becoming like more digital every year. Like we now have, as I was discussing at the start of this podcast, that we have a lot of portals, we have telehealth, we have wearable devices, we have remote patient monitoring, and especially like before COVID, like many patients and organizations saw virtual care as optional, but after the pandemic, like digital access became a normal expectation for many patients. Uh, so my question is, where do you think digital tools are helping healthcare teams the most today, especially in the patient education, access, and chronic condition management?
Yeah, that's a great question because virtual things like virtual visits
Hmm.
and those kinds of options have been really great for a lot of people, particularly with more advanced COPD. It
Hmm.
can be really challenging to get out and about when you can't breathe,
Yeah.
or when you're on oxygen therapy. So, again, a lot of these chronic respiratory conditions, it makes it easier for a lot of people to actually make most of their appointments. I mean, clearly there are some things you can't do virtually, but it makes it easier to do that. Makes it easier to do certain therapies. One of the biggest most beneficial therapies we have is this thing called pulmonary rehabilitation. But it can be hard to get into a program. And it's, again, the logistics of getting there. It can be up to 3 times a week. We now have virtual options for that, where people can get a kit in the mail and they have clinical monitoring and they work with somebody on a video conference. And, they can do the exercises and kind of rebuild their cardiovascular capacity that way. So there, and again, sometimes it comes back down to support. At the foundation, we host a couple of different monthly support group meetings. I run one that is specific to folks on oxygen therapy, regardless of disease state. We have people with COPD, people with pulmonary hypertension, people with pulmonary fibrosis. And again, it really helps people see that they're not alone on the journey. They're not weird. They're not unusual. There are other people that are going through the same things, and they can get support. They can get advice and all of that without even leaving the home, which can be really beneficial for a lot of people.
Got it. So it seems like you're suggesting, along with all this digitization, there should be a human touch as well. You need to be connected with the patients and you need to be delivering as much as you can pay back, right?
Absolutely. I mean, as much as we talk about, the world of artificial, quote unquote, intelligence
Hmm.
these days, It's still not truly that. You can only do so much with some of these models and things,
Yeah.
and you really need that personal interaction at some point in the chain. I mean, I'm sure we'll talk about where that can be very useful, but you still need to have that contact because the decision making, there's still no replacement for clinical decision making from an expert who's seen a few things. And B, again, some people just will respond better to face, even if it's on a screen.
Yep. And I think there is a patient trust thingy as well. Like what I have seen, like one major concern is that tech can sometimes create distance between patient and providers. Like a patient may be like they can receive automated messages, they can receive notification, they can see the updates, they can see their test results, but still feel that no one is actually listening to them. So this is where like trust becomes very important. So in your experience, how can healthcare teams like still use digital tools in a way, but keeping that the trust is over there instead of making care feel cold or transactional? It's more kind of personal.
Boy, that's really interesting because
Mhm.
unfortunately, I think the idea of care being kind of cold and impersonal, it kind of permeates our entire system right now because it's not even so much the application of technology, it's the structure. I mean, these primary care visits that are 15 minutes, and because of quality things and regulations, your healthcare practitioner might have their face buried in a screen for half of that encounter.
Yeah.
And so when you're starting at that baseline and then you're adding, you're making it even arguably a little bit colder by replacing a phone call with text on a screen or something like that. That's a challenge. So there's not an easy answer for that. It's judicious use. I mean, like everything in
Mhm.
moderation. And so sometimes you're going to need to make a phone call. Sometimes a text is okay. A lot of it's going to come down to patient preference. And I think probably the most important thing then is to make sure the clinician and the patient are on the same page with how do you like to receive information? How do you prefer to receive information? How can we communicate with each other better?
Yep. And from communication, like I was just thinking, like sometime if I book a appointment with a doctor, I get a message, automated message, like your appointment is scheduled. So versus getting this message, and sometimes like if you are getting a message like we look forward to seeing you and supporting your care, do you see like the messaging and the tone does matter as well, this kind of automation?
To a degree, but again, that can come down to some personal things. I mean, I actually
Hmm.
just I was making a phone call just the other day, and
Right.
there was a recorded voice, a human voice
Uh-huh.
saying, "We look forward to servicing you when
Hmm.
an agent is available." And yeah, it's great terminology, but you can tell by the inflection was very flat and everything else. So if there's not authenticity behind it, it doesn't really matter whether it's text, whether it's person, whatever it is. It's got to be um, honest.
Got it. So let's talk about respiratory care and chronic disease management because you have most of your like experience and you are working as a senior director right now at a COPD foundation, right? Tell us about this foundation. Like, what does this foundation do, and what is your role?
Yeah, so we've been around for about actually I believe it's 21 years at this point, and we are
Hmm.
the primary advocacy organization for chronic obstructive pulmonary disease in the U.S. We are starting to grow a little bit in the international space. We also cover some related conditions like bronchiectasis, and this is a mouthful: non-tuberculosis, mycobacterium lung disease. It's one of our
Hmm.
bigger initiatives these days. A lot of what we do is education and support. We are a very patient-focused organization, patient and caregiver-focused, I should say. We do a lot of advocacy work as well. We have an annual day in the spring where we take a bunch of people to Washington D.C. to speak with their senators and representatives to on various legislative issues like access to therapies and research funding and all that sort of thing. And speaking of research, we do have an arm that does do some clinical and some subjective research, support focus groups and surveys and that sort of thing. So we have a couple of different arms, and we try to essentially, at the end of the day, our mission is to make life better for those millions of people who live with COPD and the millions more who don't know it yet, and to help find those folks.
Got it. So it seems like you guys have focus on both sides, patient treatment and advocacy side as well. So tell me, like, what kind of technology or tools you guys are using, but keeping the human touch in place as well.
Well, I mentioned we have a couple of different support groups every month. We have one for oxygen therapy. We have a general one. We have one for the bronchiectasis side. We also have on our website, copdfoundation.org, we have a social media site that we call COPD 360 Social, where people can post questions or make comments and get support from the community or from some of our clinical team or whoever is most appropriate to answer. Again, we do a lot of we do webinars. We're starting to venture into the podcast realm ourselves. So we use a lot. We try to hit a lot of different, multimedia, multi-channel areas, so that again, everybody prefers to receive information in different ways. Yeah. So those folks who like to read, we've got blogs. Those people who like podcasts, that would like to listen, we've got podcasts, we've got videos, et cetera, et cetera. So we try, and we're always looking for new ways to reach folks too.
Got it. So it seems like you guys are pushing a lot of content through different channels and through different sources, so people can be educated more and more about the COPD and all this stuff, right?
Yes, absolutely. And we've even tried to go outside the strictly COPD realm because we know that awareness is a huge issue. You mentioned COPD is one of the leading causes of death in the U.S., but understanding of it, especially in the general public, is very low. So last year we took some of our funds and we started public service announcements on radio stations across the country. Just getting people to think about, well, if you have some of these symptoms, maybe you should talk to your doctor about getting a diagnosis. We took out a billboard in Times Square for a couple of days. And then on COPD Awareness Day, World COPD Day in November, we have a campaign where we get monuments and landmarks across the world to turn orange. Orange is the advocacy color. So, for example, we had Niagara Falls turn orange for a couple hours on World COPD Day. So we're trying to branch out into other things, again, to reach the general public as well.
Got it. Yep. I think that's really like adding the value and definitely spreading the awareness about this. So let's talk about digital overload. So Mike, based on your experience, like the way you were just discussing that when you go to any clinical appointment, most of the time the provider is looking to the monitor and they are just typing. So do you think these digital tools are making a lot of overheads, a lot of paperwork and a lot of data entry for providers and for clinical staff instead of focusing on the core problem?
Yes and no. Again, it's how the technology is implemented. I mean, certainly there can be a lot of hoops to jump through, but also sometimes that can be a good thing. If you have somebody, for example, we have a particular, in order to officially, by any clinical practice guideline to be diagnosed with COPD, you have to have a test called spirometry, where it tests how well the air gets in and out of your lung. In order to be officially diagnosed with COPD by any clinical practice guideline, you have to have a test called spirometry, which is where you blow through a tube and you see how well the air gets in and out of your lungs. Unfortunately, what we see is a lot of folks are diagnosed kind of empirically, where, okay, maybe you've had a smoking history and you've got some of these symptoms, and we're just going to say that you have COPD and we're just going to treat it like that. But a lot of these symptoms are also very non-specific, cough, shortness of breath, things like that. Back before I was with the foundation, when I was in primary care, we had somebody who had a very severe case of postnasal drip from their occupational exposures, was treated like somebody with COPD for many years, not getting any better. And as soon as we actually did the testing and found out what the real problem was, they were able to get on the right therapy and get better. And so one of the upsides to some of this technology in the electronic medical record is if you have somebody who has a diagnosis code of COPD, but they've never had any testing for it, or it's been years since they've had any kind of evaluation, the system can put up a flag and say, look, before you do anything else, refer this person for pulmonary function testing. So, again, it's if the system requires you to get buried in minutia and clicks and checking boxes and things like that, it's not so much of a benefit, but there are some ways where it really can help.
Yep. So from same thing, since you have been on the advocacy side and patient voice, so like you understand how important it is to include the patient voice in the healthcare decisions. And I see that many of these digital tools are built by tech teams, but not always with enough input from the patient, caregivers, or frontline clinicians who are the real user of these systems. And I understand that this can create a gap between what looks impressive in a demo and how does it actually work in a real life. So, Mike, according to you, how important it is to involve patients and clinical teams when we are designing any tech solution or healthcare solution to take their
No,
opinions?
I would say it's essential. I tell
Mm-hmm.
people all the time, I can tell you about COPD. I can tell you what the symptoms are like. I can go all day about, the science behind it and everything else, but I can't tell you what it feels like. I don't have COPD. And
Mm-hmm.
so when I'm looking outside in, my priorities may be very different than somebody who has that lived experience and things that I don't know, or I've overlooked, or I assume, or things like that. And I think that that's the case when it comes to designing treatment plans, and that's the case when it comes to designing technology. I'm a geek myself. I love technology, but a software designer or something like that may have entirely different assumptions and understandings and priorities than somebody who actually has to use the thing on a daily basis. And what may seem straightforward in code or things like that may be incredibly complicated and obtuse when you're actually executing that and trying to integrate it into a workflow. So regardless of the setting, I think having the end user in mind and getting their consultation in that, having them involved in the process is absolutely essential.
Yep, 100% and totally agree. So, AI is becoming a very major topic in the healthcare, and we all hear about AI every day. So, what are your thoughts, Mike? Is it really helping in different areas of health and care, or what do you think?
Again, yes and no. There's a lot of
Mhm.
nuance to this. For example, I know a lot of clinicians are using it to maybe simplify their notes. As long
Yeah.
as the AI isn't like generating the note, I don't think it's quite ready for that yet. And I've heard a lot of stories about, getting, people talk about AI hallucinations and things like that, what it's hearing and what it's trying to
Mhm.
assemble and all that. But if you give it a block of text and you say, simplify this, or take these data sets and do that, if you give it specific instructions, that can work really well.
Mhm.
So I think that's a good use for it. I know there are some emerging uses for it. There was some research done out, I believe it was Intermountain Health in Utah, that actually had an AI agent talking with some folks who were on there, helping them with disease management, and it would help them
Mhm.
through symptoms and things like that. And that seemed to work pretty well until it realized that, okay, this person actually does need to be escalated to a human. So I think there's a lot of emerging use for it. And I think there's a lot of benefit, but again, it really comes down to specific applications.
Right. Do you think it can play any role in diagnostics, specifically in the COPD and these like chronic diseases?
I think so. I think those are the kind of data that, as I understand it, these large models really work well with. They can look at a whole constellation of data points from a patient and say, well, I guess I'll back up a little bit. I don't know that I would want it to explicitly make the diagnosis, but I think it's really good at saying, hey, clinician, have you considered this? Have you, here's a list of possible, it'll cut down the differential diagnosis a lot more because it's looking at things that, again, maybe aren't obvious, or they've been buried in a medical record somewhere and aren't, popping up to the front, because the visit times are short and everything else. So I think it's still in the decision support tool phase right now. Whether it gets to really a place where it can make a diagnosis, it's hard to say. But I think
Mhm.
it can definitely be a great assistant.
Got it. So great assistant with the human involvement, right? Human should be in
Absolutely.
the loop, right?
Absolutely.
And how about the costing? Can it make the care cheaper and accessible, especially to the third world countries where people don't have access to the providers and the clinical care?
Potentially, again, I think you're still probably in many places going to have a human at that end of the loop because
Mm-hmm.
again, a lot of these places people may not be very familiar with the
Yep.
technology. There are places that don't necessarily even have reliable electricity. So if you don't have power, then a lot of your fancy gadgets aren't going to work anyway. So again, there's a role for it. And you talk about access also. Yes, absolutely. Because then you can have consultations with people who are across the country, across the continent, across the globe, experts and everything else. So I definitely think there is a role for it to play. Again, it's just I sound like a broken record, but it's down to how it's implemented.
Right. And then there are like people are very concerned about privacy, security, compliances, which especially like EPHI and the HIPAA compliances. And people saying that there should be proper security guardrails to ensure that no patient information is used for any other purposes. So what do you think about that, especially these compliances that we have, especially in the US?
Yeah, I think that's appropriate. Again, across the continuum of healthcare. I think the added risk with this is that a company, an unscrupulous company, will say may use some of those data for again modeling or things like that without consent, and that's where they may sell some of that information to an insurance provider. I know that's a lot of where people are concerned with like who is ultimately going to see this. Is it going to affect my life later on? Rates that I pay or access to therapies, decision making like that. I think those are very valid concerns and probably things that haven't been contemplated in the past. But I mean, we all know that privacy is precious, especially when it comes to our medical records. So I don't know that there's too much of additional concern, but it's definitely something that we need to be aware of.
Yep, 100% and totally agreed. So, Mike, I would like to discuss about like practical advice for healthcare teams, especially many healthcare teams who are looking to modernize, but they may not know where to start. Like for example, are patient missing follow-ups? Are clinician overwhelmed with the documentation? Are patient confused after discharge? So there may be a lot of these kind of different use cases. So if a healthcare organization want to adopt digital tools while keeping care personal, what should be the first step? What advice do you have for them?
Well, in order to solve the problem, you have to identify the problem. And in order to do that, then you're going to have to ask. You're going to have to do some surveys of your staff, your patients, all the stakeholders, and say, what is missing? To your point, are people missing follow-ups? If so, why? Are they not getting the texts? Do they not like text? Or would they prefer email? Would they like, what is the scope of the problem? And then identify the tool that can fix that. And similarly, with your clinical staff, asking them what's going to make your day easier rather than saying, this is great technology and this is the latest and greatest new thing and we're going to implement this right now. Good luck. The top-down approach isn't going to work very well. Again, it comes back to getting that end user input and support and collaboration to figure out where the gaps are, where the problems are, and then select the tool instead of trying to force the tool onto other problems.
Got it. Right. So if we talk about the future of the care, like looking ahead, like healthcare will likely become more connected, more data driven, and more tech enabled. But the goal should not only be faster care, it should be better care, more accessible, and more compassionate care. So what does the ideal future of digital healthcare look like to you based on all the advancement that is happening now?
Wow, that's a question. The future of digital health should be, again, as a companion. We've clinicians, since time immemorial, have had resources, whether it's books, whether it's apps, whatever it is, that help them make decisions. Where technology can help, and artificial intelligence and everything else, is to make those decisions a little bit easier and to take some of the minutia out of it. Again, some of the lower level documentation and charting, those are things that can easily be handed off. We can have better integration with, if you every time you go to a visit, you get your blood pressure taken, temperature, oxygen saturation, all those sorts of things. Instead of having all those done and then having somebody manually type it in, have better connectivity from the devices to automatically import those things, and start populating the visit note and things like that. So there's a the ideal future is going to be where these tools exist to improve efficiency and let the clinician have more of that compassionate personal time with the person rather than worrying about checking all the boxes and clicking all the links.
Great. Yep. I totally agree on that. So, Mike, let's have a quick rapid fire round. So, I will ask some questions. You can have a short answer, and that are totally fine. Let me know when you're ready.
Let's go.
All right. So, one digital tool healthcare teams should use more wisely.
In my experience, it's like the check-in software. I've worked with some really good visit check-in software, and I've worked with some that's so redundant. I've had the enter my information 3 separate times. So be again very judicious at how those things are implemented, so that it's not adding to clinical burden or patient burden.
And one technology trend that excites you.
Interconnectivity, again, getting devices to speak to each other and automatically import information, and even some of the interfacing with patients. Again, it talks about those virtual agents that can carry conversations and things like that. Again, supervised fashion. I think those tools are very exciting.
And one tech trend that worries you.
Accumulation of big data sets, because again, they can be very helpful for population health and things like that, but they can also reveal a lot of information that can be potentially negative to people.
Yep. Telehealth overhyped or still underused?
I'd say still underused. I think, again, with therapies and visits and things like that, I think we need to start looking at what's best for the individual, what can be done with a telehealth visit, and try to shift people when they're comfortable, shift people to that.
AI in healthcare, is it assistant or disruptor?
I think right now it still tilts a little bit disruptor, but I do think that it's getting to assistant, and I think we'll be able to get there.
And Mike, if you could fix one thing in healthcare tech tomorrow, what would it be?
Wow, one thing in healthcare tech. I think a lot of user interfaces are still pretty clunky. Whether it's EMR, whether it's certain devices, things like that. I think they're non-intuitive. They're excessively complicated. They weren't designed with the end user in mind. And I think if I could wave my magic wand, I would make them all perfect.
Great, and totally agree on these legacy EMR and EHR. Well, Mike, you played it very well. Thank you for very insightful conversation. So, Mike, before we close, what is one message you would like to share with the healthcare leaders, tech companies, and care teams who are trying to use digital tools without losing the human side of care?
Don't get too lost in them. Remember that there is still this human element here. There is no replacement for human clinical decision making. They are a tool. They are not the tool. They can be part of the toolbox, but you just again don't fall into the trap of it's new, it's shiny, it's got to be the best. I've got to use this, and I'm going to rely on it better than I rely on myself.
Well, thank you, Mike, for joining us on the Better Health Tech podcast and sharing your perspective on digital health, respiratory care, and advocacy and patient-centered care. The key takeaway from today's conversation is that tech should not replace human care, it should support it. Thank you again. And to our listener, thank you for joining us. Stay connected with Better Health Tech for more conversation on healthcare innovation, digital transformation, and the future of patient-centered care. Thank you.
Thank you.